Dr. Qureshi, test 1, 2, test, test, test. Where am I? Oh, you have me down. You can go ahead and start. I'm sorry about that.
Just let me know when to start.
Again, let's welcome Dr. Adnan Qureshi.
Well, first of all, thank you so much for inviting me. I'm really sad that I couldn't be there in person. I really love coming to this conference. So I was actually going to talk about balloon-expandable versus self-expanding stents for intracranial arterial stenosis. So all of you know that intracranial atherosclerosis is associated with a high risk of recurrent ischemic events. So somebody who has a symptomatic intracranial stenosis, meaning that they have a high-grade intracranial stenosis associated with a cerebral ischemic symptom, the risk of actually having a second ischemic event is very high. And as you can see, it may be as high as 52% over the next 3 months. And that doesn't include patients who actually have asymptomatic lesions. So if you just look at patients and follow them with serial MRI, a large proportion of them would also have asymptomatic ischemic events to the brain. So clearly a disease with a high risk of recurrent cerebral ischemic events, despite the best medical treatment that we have. So intracranial angioplasty and stent has been proposed. And the mechanism of benefit is the following, that if you look at ischemic events that happen or occur in association with intracranial atherosclerosis, usually it's a plaque. A lot of time the plaque would actually lead to hypoperfusion because of luminal reduction. So there is reduction in cerebral blood flow to the brain. Sometimes the plaque may be a source of embolus. And sometimes there may be superimposed thrombosis leading to complete occlusion of the blood vessel. So when we do angioplasty and stent placement, essentially you are increasing the diameter of the vessel to improve perfusion. And also there is a certain level of remodeling that reduces the thrombogenicity of the plaque or the stenosis. And this is actually a middle cerebral artery stenosis, and this is after the stent placement. And this is essentially what the vessel looks like. So unfortunately, this patient died 7 months later because of a contralateral intracerebral hemorrhage, but it allowed us to look at the cross-section of the blood vessels. And you can actually see that there is the struts of the stent, and the endothelium has actually grown over the struts of the stent. And it's also, this is a lenticostrid artery, and you can see there's enough space between the struts of the stent that allow the patency of the lenticostrid artery. So this is the concept of remodeling after angioplasty and stent placement. Now the issue is that stents come in two types. One is what we call as a self-expanding stent. So essentially the stent is advanced in a compressed fashion, and as you retrieve the outer sheet, the stent expands by virtue of biomechanical properties, and we call it self-expanding stent. The second stent is balloon-expandable stent, where the stent is actually mounted on the balloon. So when the balloon actually inflates, the stent actually inflates with the balloon, and then once you deflate the balloon, the stent has already been stretched past its elastic coefficient, so it cannot retract and retains in an expanded manner. So both of these stents are actually available. And we always talk about broad properties of stent, but we have to recognize that there are several aspects of the stent that go into play when we look at the results of angioplasty and stent placement. There are things like dog boning, which means that the stent actually at the edge may increase more than actually in the center. The stent may recoil. So once you deploy, it may actually recoil. Obviously, in the long term, there can be restenosis. The stent may actually change its size after deployment. So there are several aspects that the stent design actually becomes important if you're looking at the results of stent placement. Now, the balloon expandable stents obviously have some advantages. It has high radial force. The self-expanding stents obviously have low radial force. On the other hand, it actually does increase the lumen diameter, but it actually does cause arterial injury, which can be a concern. The deployment can be very precise. With the self-expanding stents, the deployment may somewhat be unpredictable. Obviously, the balloon expandable stents are rigid, while the self-expanding is more flexible. And then the stent length may be constant. With self-expanding stent, depending on the diameter it's expanding, the stent length may actually change. And after deployment, angioplasty is common after balloon expandable stents, but with self-expanding stents, particularly intracranial self-expanding stents, placing another balloon through that stent may actually displace the stent. And again, stents can be made of different materials. So, I know we use the term broadly as stent, but again, the stents are not the same. Different materials have been used, nitinol, stainless steel. Most of the intracranial stents we have are really made of stainless steel. Obviously, they're the cobalt chromium alloys and now the WE43 alloys. And each of them have different properties, particularly in regards to tensile stent and its elastic modulus. Now, the initial work, actually, the large trials initially started with self-expanding stents. All the balloon expanding stents were used in the 90s, but those stents were made for coronary circulation and were very rigid, so it was very difficult to deploy those stents in the intracranial circulation. So subsequently, self-expanding stents became more popular. And all of you are aware of the stenting and aggressive medical management for preventing recurrent strokes in intracranial stenosis, or the SAMPRESS trial, that actually looked at patients and randomized them to either best medical treatment or best medical treatment with self-expanding stent, with the emphasis that the stent be done as soon as possible. But essentially, the trial, if you just look at the 1 month risk of stroke or death, it was 14% in the stent group, only 6% in the best medical treatment group. Obviously, a very high rate of stroke and death after stent placement or self-expanding stent pretty much took away any chance of a benefit of stent placement in the long-term outcome. And essentially, you can see in the long-term outcomes, 20% of the patients had a primary endpoint of 1 month stroke or death or 2-year ipsilateral stroke. With the stent group, only 12% of the best medical group. So obviously the stent placement was not recommended. And it also prompted the FDA to change the criteria of wingspan, which is the self-expanding stent. So before, the criteria used to be that you can do it with severity between 50 and 99%. The new criteria, you have to do it between 70 to 99%. Previously, you could have any symptomatic lesion. Now the FDA required at least 2 or more ischemic strokes. And they also required medication failure. So you already had to be on an antiplatelet agent before you actually were considered stent placement. And they also put this limit to actually wait 7 days between the ischemic event and performing the stent placement, because they were concerned the stent in the early period after ischemic events may actually have a higher risk of stroke or death. So subsequently, the SAMPRESS data has been reanalyzed. And if you look at the new on-label design, although only a small proportion of patients met that criteria, but yeah, it does actually appear the stent placement may have a little more favorable effect than actually in the off-label criteria. And then obviously the post-marketing surveillance study was done, called the WEAVE, or the Wingspan Stent System post-marketing surveillance study, that looked at 152 patients using the new on-label criteria. And again, showing that the 3-day or the 72-hour endpoints, the risk of stroke or death was actually pretty small in the on-label criteria. So maybe patient selection more than the stent itself was the reason. And this actually ended up being the evolution since 2005 when self-expanding stent, or the wingspan stent, was approved. It was actually approved based on an international trial, so none of the patients were actually recruited in United States. and it got what was called an HDE, or the Humanitarian Device Exemption, which means that it can be used in a small proportion of patients. And this was the existing criteria of the FDA, which we talked about. Subsequently, the post-marketing US registries were performed. But then after the results of the stent in 2012, the FDA modified the criteria. So the eligibility criteria became more narrow, as we just talked about. And then after the VIV registry in 2019, the FDA actually issued another advisory, strongly recommending against off-label use of this particular device or the self-expanding stent. So the question was that perhaps in patients who are on label, maybe a self-expanding stent can actually provide better results. So this was actually the China Angioplasty stenting for symptomatic intracranial severe stenosis, or the CASES trial. And if you look at 380 patients in 10 centers in China, and obviously the patients who randomized had actually a symptomatic severe intracranial stenosis. But interestingly, there were two things in this particular trial that one needs to notice. One, the ischemic event had to be within the last 12 months, so a large window. So obviously, the further away you are from the ischemic event, the less the risk of having another ischemic event. So the control group already is more favorable than usual. And a small proportion of patients had received antiplatelet agents prior to qualifying ischemic event. So even in this trial, somehow the patient population was not necessarily ideal, but perhaps more suited for a fast recruitment. But they waited at least 3 weeks from the latest ischemic event before doing the stent. And if you look at the 1-month results, so 176 patients got the stent, 182 patients got best medical treatment. The 1-month stroke and death rate was 5.1% with the stent placement. So that is actually much better than what was seen in the Sampras trial. So obviously, using these criteria, you can select a group of patients where the procedure itself can be performed with an acceptable rate of stroke or death within 1 month. But on the other hand, the best medical treatment, the 1-month risk was 2.2%, which is actually lower than the 6% that was observed in the Sampras trial. So the patient selection criteria also selected a group of patients who were at low risk of cerebral ischemic events with medical treatment. And by the time you finish your 2-year follow-up, there appears to be no difference in the 2-year risk of ipsilateral stroke. It's 9.9% in the stent group and 9% in the best medical treatment group. And that actually prompted people to rethink that maybe we've been emphasizing on patient selection criteria, and perhaps that is quite important. But maybe we also need to look at the fact that maybe self-expanding stent is just not the right stent for intracranial stenosis. And that was actually highlighted with some pioneering work by Dr. Hassan. So there is this Resolute Onyx stent, which is a balloon-expandable stent. It's also a drug-eluting stent. And they actually compared the results in 184 patients. So 58 patients got the drug-eluting stent, the balloon-expandable stent, and 126 were treated with the self-expanding stent. So if you look at the rate of ischemic or hemorrhagic stroke or death within 72 hours of the procedure, you can see there's a dramatic difference. The balloon-expandable stent is only 1.7%, self-expanding stent is 6.3%. So there clearly seems to be some difference with balloon-expandable stents when it comes to self-expanding stents when we're talking about intracranial stenosis. And the difference actually is sustained. So in their study, they followed these patients, and in patients who had a complete follow-up, interestingly, the risk of actually having a new stroke or death during follow-up, 8.9% in the self-expanding group. None of the people in the drug-eluting or the balloon-expandable stent actually had an ischemic event. So again, the results are actually better in the short term and the long term, although this is not a randomized clinical trial, and there can be differences between the two groups that we do not know about. But nonetheless, it is actually pretty encouraging that balloon-expandable stents today can provide a better result than self-expanding stents. And now this was actually even a larger study. And that actually took all the data from 8 centers. So 8 centers that actually performed a balloon expandable stent, the Onyx Resolute stent. And obviously you have patients who were treated in the Sampras group and patients who were actually treated in the Sampras group with a self-expanding stent. So if you look at the 12 to 30 days stroke or death rate, 2.6% in this drug-eluting stents or the balloon expandable stents, 6.6% in the best medical treatment of Sampras, and 15.6% with self-expanding stents in the Sampras group. Now, granted that the ascertainment methods are different. This is self-ascertainment. These were independent ascertainment. So obviously there is a greater level of sensitivity for detecting stroke or death. But nonetheless, major strokes or death are not really underreported regardless of the methodology. So this clearly was showing that if you use balloon expandable stent, not only you look much better than the self-expanding stent, you may actually look better than medical treatment in the Sampras that was superior to self-expanding stents. So then actually did a propensity adjustment, so matching the clinical characteristics of the patient. So you have 115 patients treated with the drug-eluting stent, you have 115 patients treated with a self-expanding stent. And the characteristics have been matched to what we call as propensity adjustment. And even after the adjustment, the dramatic difference still remains. 2.6% of the drug-eluting stent had a 30-day rate of stroke or death, a very low rate compared to 15.6% with the self-expanding stent. So clearly, I think that where we are starting to recognize that maybe balloon expandable stents, the new generation of balloon expandable stents, are perhaps superior to self-expanding stents, which we have used in the previous clinical trial, and perhaps it's a time for a redo. Actually re-evaluate stents with the balloon expandable stents rather than the self-expanding stent. And whether it actually has any importance to use a drug-eluting stent versus a bare metal stent. And there was the study done in China that actually randomized 263 patients in 16 centers. And this was actually, again, patients who had a stroke within 90 days before trial enrollment, had failed an antiplatelet agent, and had 70 to 99% stenosis. So actually, the criteria being more compatible with what the FDA on-label criteria is. So 263 patients were randomized. So 123 to the drug-eluting stent, 131 to the bare metal stent. So 1 month stroke and death is a little higher with drug-eluting stent at 7.3% as compared to 5.6% with the balloon expandable stent. But regardless, if you look at these numbers, they compare very favorably with the self-expanding stent that was used in the Sampras, actually had a 1 month stroke death and rate of 15.3%. So the bare metal stent, whether it's drug-eluting or not, appears to do much better, at least in the Chinese population, than the self-expanding stent in the US population. And interestingly, if you look at the rate of ischemic stroke over the next 1 year, 0.8% with the drug-eluting stent and 6.9% with the bare metal stent. So there appears to be a benefit of drug-eluting stent over bare metal stent. As we look at the long-term risk, at least a 1 year risk of having an ischemic stroke in the distribution of the intracranial stenosis. And it appears mainly because of in-stent restenosis. So all of these patients actually had a follow-up cerebral angiogram or a CT angiogram. And if you look at restenosis, the rate was significantly lower with drug-eluting stent with 9.6% as compared to 30.2% with the bare metal stent. So maybe there is some evidence of balloon expandable stent being the right stent and maybe some value of the drug-eluting characteristics of the balloon expandable stent. So balloon expandable stents, particularly drug-eluting stent, may be the future of intracranial angioplasty and stent placement. So we are actually in a very dynamic environment. So, we started with intracranial angioplasty and stent placement. We initially started with balloon-expandable stents, the ones that were used in the coronary circulation. However, because of the lack of tractability, we actually moved to the self-expanding stents. And then essentially after Sampras, we modified the eligibility criteria. We actually put more emphasis on antiplatelet medication, monitoring the therapeutic effect of antiplatelet medication. And then subsequently, where we are today, we are back to actually using the new generation of balloon expandable stents, perhaps the drug-eluting stents. And one would say that this may be a perfect time for a randomized clinical trial, or maybe we don't even need a trial. We can actually just go ahead with existing evidence and use balloon expandable stent. Now, the issue obviously is that medical treatment also is dynamic. So really the medical treatment that was used in the Sampras trial may not necessarily be the existing medical treatment or the contemporary medical treatment. We have a new generation of antiplatelet anticoagulant medication. We even have new medication that can reduce serum triglycerides. So we've always focused on the serum LDL cholesterol. Now we actually may have the serum triglyceride lowering medication as well. So the randomized clinical trial obviously has to look at two dynamic and equally fast-paced moving arms, the stents and obviously the medical treatment. So the American Academy of Neurology Guidelines Committee in 2022 recommended the following for stroke prevention in symptomatic large artery intracranial atherosclerosis: that aspirin and clopidogrel is better than aspirin for up to 90 days to reduce the risk of stroke in patients with severe intracranial stenosis. Actually, severity is defined by 70 to 99%. They also mentioned those patients should be a low risk for hemorrhagic transformation, although they do not specify what those low risk criteria are. High intensity statin treatment, so actually the goal of LDL cholesterol to take it less than 70 milligram per deciliter, and long-term blood pressure target of less than 140 by 90 millimeter, and at least moderate physical activity are also recommended. They do not recommend the stent for patients for stroke prevention in those who have moderate severity stenosis, 50 to 69%, or as the initial treatment for stroke in patients with severe stenosis, again 70 to 99%. So they are emphasizing on this medical treatment failure before actually considering stent placement. And obviously they do not comment about the type of the stent. They simply leave it broad that intracranial stent placement may be considered if you have medication failure in the presence of severe intracranial stenosis. So I'm actually going to conclude here with the following statements. Intracranial atherosclerosis is no longer an untreatable cause of stroke. Aggressive management, medical management can reduce recurrent ischemic events and perhaps even cognitive deficits that we haven't talked about in patients with intracranial atherosclerosis. Endovascular treatment remains a promising strategy, and defining the optimal stent design is an integral part of enhancing the therapeutic potential of this particular strategy. And we as practitioners must support future clinical trials to ensure that the treatment of intracranial atherosclerosis is evidence-based and impacts favorably upon patient care. Thank you.
Dr. Qureshi, thank you so much. Can I ask you a question?
Sure.
This is Sunil Sheth from Houston.
Go ahead.
Great. I was just wondering, it's a great description of where we've come in our history of stents and stent designs. And so if you in your experience had to design an ideal stent, what would be those characteristics and what's different from the devices we have currently?
So the number one desirable attribute of an intracranial stent is trackability. It trumps every other criteria. So then it comes down to what features actually determine trackability. And this wire over the wire designs don't seem to provide the same benefit as essentially a monorail system. So I think it would have to be a monorail system. I think that there are certain other attributes, and the, I guess in the interest of being transparent, I've been quite involved in stent designs for intracranial stenosis. But I think the other attributes obviously are the recoil, the strut thickness. I think that that's something we haven't talked about, and the stent material. So you have to actually define what is the appropriate strut thickness. So the Resolute Onyx struts are actually 81 microns, but in the current design paradigm, you can actually go much lower than that. So we have the thin struts and we have the ultra thin struts. The amount of, I think that there is this interlinking. So each stent is made of rings, and the rings have to be connected to each other, and the number of connections also define the flexibility of the stent. So obviously that's another attribute. And in terms of materials, I think that the existing balloon expandable stents were made of stainless steel, and they haven't really shown the benefit, and perhaps they were also too rigid to deploy. So I think now there is a opening for defining new materials, how to build the stents. So I think you'll be seeing more of the cobalt chromium alloy. Then actually there's a new alloy that actually is even better, or performing almost equal to cobalt chromium, but both of them actually perform better than stainless steel. And one of the things that people actually have been talking about is the nickel content. So stainless steel obviously has more nickel content than cobalt chromium and some of the new generation alloys. So you'll be seeing a lot more in terms of stent designs, and perhaps the value of these new stent denied or the innovative stent denied, it may not be so much in the coronary circulation where they're already near optimal, but actually perhaps more for the intracranial circulation.
Thank you, Dr. Qureshi. This is for Alabos. Hope all is well.
Hey,
Is there a role for the bioabsorbable technology in intracranial stenosis?
So there are two challenges to that. The most common bioabsorbable stents actually initially were the magnesium stents, and now they actually have some amide stents. The one is actually that the stents are somewhat more friable, and there is a little risk of stent fragmentation. And so that's why there's some hesitation for intracranial atherosclerosis because of that, that if the stent actually fragments, because it doesn't necessarily have the same structural integrity of the existing metal stent that are non-absorbable. The other thing which actually is interesting in the coronary circulation is that in the initial part, the results may be the same, but as the stent actually gets resorbed, the restenosis rate is actually higher. So perhaps the lack of metal in the long term actually makes the vessel more prone to restenosis. Now they are actually trying to add new drugs to it. So it's possible in the next 5 years, maybe that will not be a concern, because the new drugs that are actually being added to the material may be enough to prevent long-term restenosis. And in fact, the newest design actually is a mixture. The drug and the bioabsorbable platform are really one compound. So the stent is made of one compound. So I think that we may see more of the bioabsorbable stents. Obviously, there is interest, because then if you have bioabsorbable stents, you may not need antiplatelet agents for a long period of time. Particularly in the coronary circulation, it's an issue because they always use the drug-eluting stents. And once you have a drug-eluting stent, you're pretty much condemned to have dual antiplatelets at least for a year.
Thank you very much, Dr. Qureshi. So a quick question that we always get a lot is angioplasty alone versus stenting. We did a lot of it during the WEAVE trial. We were a site and we were not allowed to use wingspan unless the patient met study criteria. So in those patients, we tried a lot of angioplasty alone, and angioplasty then would drop an atlas. We don't have drug-eluting balloons in the US, but do you think that's a possible route for future ICAD treatment?
That's a very, very interesting question, because if you look at the comparisons between primary angioplasty and stent placement for intracranial circulation, it appears that the 1 month stroke and death rate is pretty low with primary angioplasty. And obviously the balloons always track better than the stents. So the residual stenosis is obviously different. So obviously, if you do a primary angioplasty, the residual stenosis may actually be greater than if you do a stent placement. Now, the question obviously is that, does it really matter? And I think that so far we haven't seen a convincing difference that, a residual stenosis of 45% or 35% is any inferior to a residual stenosis of 15%. Because in the end, the primary goal is to prevent a recurrent ischemic event, a clinically symptomatic ischemic event. So that's the primary goal of all of this. Whatever the angiogram image looks like is perhaps only just a secondary goal, subservient to the primary goal. So I think that, we don't really know the answer that, maybe primary angioplasty alone may just be enough in addition, rather than a stent placement. But I think that some of the more recent trials where the follow-ups have gone more than 1 year, maybe there is some value in preventing restenosis. Obviously, the risk of restenosis is higher if you just do primary angioplasty. In the coronary circulation, it's interesting that, stent placement has always been superior to primary angioplasty. But if you break down the endpoint, because in the coronary circulation, they always use a combined endpoint. So it's actually a recurrent myocardial infarction, death, or restenosis requiring another treatment. So the biggest difference between primary angioplasty and stent placement in the coronary circulation has been in terms of the need for a second treatment because of restenosis and not necessarily driven by clinical events.
Thank you very much, and we hope to see you next year in person.
Yes, of course, I'd love that.
Thank you again, Dr. Qureshi.